Welcome to Critical Care Fundamentals. These lectures are meant to be brief, and the goal is to give you, the busy provider, a basic framework of common critical care topics. My name is Frank Lodeserto, and I completed a combined internal medicine and pediatric residency. I then went on to do 2 fellowships in both adult and pediatric critical care. I currently work in both the adult and pediatric critical care units at Geisinger Medical Center and the Janet Weiss Children's Hospital in Danville, Pennsylvania. Today's topic is the basics of shock. My objectives are for you: number 1, to be able to define shock. Number 2, be able to discuss why lactate may be elevated in shock. And number 3, list the main categories of shock. First, let's start out with a definition of shock. Shock is a state where the metabolic supply to tissues, and therefore organ systems, does not meet the metabolic demands to these tissues and organ systems. If left untreated, these tissues may undergo irreversible injury, which can lead to organ failure and even death to your patient. Simply stated, shock is a state where tissue supply does not meet tissue demand. It is important to note that shock is not defined by a blood pressure, as a patient in shock may have normal or even elevated blood pressure. I'm going to repeat this one more time because it's essential. Shock is not defined by a blood pressure. So again, patients with shock may have normal or even elevated blood pressure. But often patients in shock do develop low blood pressure and hypotension. But as you will see, having a low blood pressure may not occur until the late stages of shock. So a key in the management of shock is early recognition and prevention from the development of hypotension. As I mentioned, shock is simply a supply-demand mismatch. Because of inadequate supply or perfusion to tissues relative to metabolic demands, these tissues may develop hypoxia and therefore undergo anaerobic metabolism, producing less ATP to meet cellular needs. If this process continues without restoring adequate perfusion and oxygen nutrient delivery, these tissues, as I mentioned before, can go through irreversible injury and death. If left untreated, you may see organ failure and even death. Now, it's believed that cells undergo anaerobic metabolism. Therefore, the presence of lactate is often believed to be a sign of poor tissue perfusion and cellular hypoxia. Let's take a closer look at lactate and lactate production in shock. Here, we will review the important biochemistry of how and why cells produce lactate. Cells will convert glycogen to glucose, and this glucose will be converted to pyruvate through the process of glycolysis. Pyruvate then has 2 options. It can, number 1, go into the mitochondria, where it can be converted first to acetyl-CoA, then enter the Krebs cycle, and eventually the energy precursors produced during the Krebs cycle will be used during oxidative phosphorylation to produce 32 to 36 ATP, or pyruvate can be converted to lactate. It is believed that pyruvate will enter the Krebs cycle if cells have adequate oxygen supply. However, if these cells develop hypoxia, pyruvate will take a different path and will be converted to lactate rather than enter the mitochondria. So the presence of lactate is therefore thought to be associated with cellular hypoxia and therefore a sign of shock and stress. However, this understanding of lactate elevation in shock is likely not entirely correct. Lactate can be produced secondary to cellular hypoxia, but likely the vast majority of lactate production during shock is actually due to aerobic, not anaerobic metabolism. Lactate production is associated with adrenergic stimulation. During shock or stress, or even high levels of exercise, epinephrine is elevated, leading to beta-2 stimulation. This process stimulates cyclic AMP to break down glycogen to glucose, and this glucose will enter and be converted to pyruvate through glycolysis, as we've just mentioned. Now, even in the setting of adequate cellular oxygen levels, some pyruvate will enter the Krebs cycle and some will be converted to lactate. This process is entirely aerobic, so it occurs because the mitochondria and the Krebs cycle are unable to keep up with the rate of conversion of glycolysis, and not because cells lack oxygen. Elevated lactate production may also have protective mechanisms and serve as an energy source for the heart, the brain, the lungs, and muscle during stress or shock. If lactate production is blocked in animal models, these animals did poorly as opposed to those who are able to utilize lactate as an energy source. Lactate also functions like a hormone, which can help signal cellular energy utilization and metabolism. Normally, lactate is produced at low levels and is typically cleared by the kidney and liver on a daily basis. I want to dispel a few myths regarding lactate before moving on to the categories of shock. Lactate levels can be elevated in shock secondary to high circulating levels of epinephrine, not cellular hypoxia, as I've just described. However, elevated lactate does not always mean your patient is hypoperfused, and it doesn't necessarily mean that they have sepsis either. Now, you can certainly see elevated lactate levels in sepsis and in shock with hypoperfusion, but they are not always synonymous. In fact, when you see elevated lactate levels, you should have a broad differential, as there are various causes of lactate elevation, as I have listed here, and that are beyond the scope of this talk. Please take a moment and pause this video to read this list before moving on. You may have heard the terms cold shock and warm shock in describing the shock state a patient is undergoing. These terms are helpful and important to relay important hemodynamic information. However, these definitions are too general, and a more precise etiology of shock and category of shock is still needed to be determined in order to adequately treat the patient. I will go through the four major categories of shock in a moment, but the terms cold shock and warm shock are useful terms to start to differentiating the categories of shock. Cold shock is a state in which a patient is having decreased or inadequate stroke volume to meet metabolic demands. As we will discuss in our next slide, a decrease in stroke volume results in either an impairment in preload or contractility, or an increase in afterload. As a result of a decrease in stroke volume, the patient's perfusion may be impaired, which may manifest as the skin feeling cold to touch, a delay in capillary refill, and decreased peripheral and even central pulses. The term warm shock is used to define a patient who has decreased vascular tone. So they have a decreased systemic vascular resistance and are vasodilated, so they feel warm to touch, have bounding peripheral pulses, and brisk or fast capillary refill. The warm skin and bounding pulses is secondary to a maldistribution of blood flow away from vital organs to non-vital organs such as the skin or muscle. The patient who is in cold shock and has a low stroke volume may develop a narrow pulse pressure, which we will discuss, and that's due to compensatory vasoconstriction and an increase in systemic vascular resistance to maintain adequate perfusion. And a patient with warm shock may have a wide pulse pressure as a result of low systemic vascular resistance. Here's my perhaps oversimplified, but I think effective approach to understanding the hemodynamics of shock. Let's start with some basics. Let's start with stroke volume. Stroke volume is the amount of blood pumped out of the heart with each heartbeat and is dependent on three important factors. Number one, preload, the volume of blood in the ventricle before ventricular contraction or at the end of diastole. A decrease in preload can be seen in hypovolemia from dehydration or hemorrhage, or even vasodilatation, which we'll talk about later. The next factor that determines stroke volume is contractility, which is basically defined as the innate ability of the myocardium, to generate strength or the force during ventricular systole or contraction, and can be impaired with ischemia, toxins, myocarditis, or some congenital heart defects. And the last factor that determines stroke volume is afterload, or the resistance opposing the ventricular contraction. Whereas a decrease in preload and contractility can cause a decrease in stroke volume, in the case of afterload, an increase in afterload will lead to impaired stroke volume, such as in the case of a hypertensive emergency or increased vasoconstriction. So let's take a closer look at what determines our systolic blood pressure and our diastolic blood pressure. Our systolic blood pressure is determined by our blood volume in the arteries as well as aortic compliance. Aortic compliance decreases with age, so our blood vessels get stiffer with time. So if we assume our compliance is fixed for a given patient, we can simply say that our systolic blood pressure correlates with our stroke volume. So another way to look at systolic blood pressure is when your arterial line or blood pressure cuff is measuring your systolic blood pressure, it's actually measuring the direct effects of your patient's stroke volume. So if your patient has a low systolic blood pressure, then it's likely they have an inadequate stroke volume, and either preload is impaired, contractility is impaired, or they may have an elevation in their afterload. After the ventricle is contracted and systole is completed, the ventricle then relaxes and diastole begins. So as your ventricle relaxes and fills with blood, you need to maintain a blood pressure or perfusion to your tissues. This is accomplished by your vascular tone or the systemic vascular resistance. So during diastole, as the ventricle is relaxing, your diastolic blood pressure and tissue perfusion is determined by your systemic vascular resistance. So when you measure your diastolic blood pressure with an arterial line or a blood pressure cuff, you're actually measuring the direct effects of systemic vascular resistance. So your diastolic blood pressure correlates with your systemic vascular resistance. And if you see a patient with a normal systolic blood pressure and a low diastolic pressure, you may have adequate stroke volume, but you may have an issue with systemic vasodilatation or systemic vascular resistance. Now, chronically, a low diastolic blood pressure and a wide pulse pressure, which is simply the difference between your systolic and your diastolic blood pressure, can be associated with things like aortic regurgitation or an infant, let's say, with patent ductus arteriosus. Clinical signs and symptoms will vary based on the type of shock a patient may present with, but patients will typically compensate in the following ways. A patient with shock who, let's say, has impaired preload or contractility or high afterload, these patients will have a decrease in stroke volume and therefore may develop a low cardiac output state and tissue perfusion. To compensate, a patient will increase their heart rate first to maintain adequate cardiac output. As cardiac output and blood pressure falls, causing a decrease in tissue perfusion, the patient will attempt to compensate by increasing vascular tone and systemic vascular resistance. So as we'll see from this, as this patient with a low stroke volume tries to compensate by increasing heart rate, when that becomes inadequate, your patient will vasoconstrict, increase systemic vascular resistance, and increase their diastolic blood pressure, narrowing their pulse pressure. Vascular tone is dependent on many factors in organ systems. Two of the main systems that determine vascular tone are the adrenal glands through a series of catecholamine, which can not only raise your heart rate, but act as receptors on blood vessels to increase vascular tone. Another important system are the kidneys, who sense a decrease in perfusion and act by releasing renin, which through a series of enzymatic processes produce angiotensin II, a potent vasoconstrictor which will increase vascular tone and raise systemic vascular resistance. This process will also trigger the release of aldosterone from the adrenal glands, which works at the level of the distal tubules and collecting ducts to increase water reabsorption. Both of these processes and others serve to increase vascular tone and raise systemic vascular resistance as well as the diastolic blood pressure. Recall, we discussed diastolic blood pressure is dependent on vascular tone. So as systolic blood pressure is lowered because of decreased stroke volume, diastolic blood pressure is raised as systemic vascular resistance is raised, thus causing a narrowing of pulse pressure. Now, let's talk about the four main categories of shock. As we'll see, it was helpful to discuss first cold shock, as cold shock is any state where there is decreased stroke volume, and warm shock, which is a decrease in our systemic vascular resistance. So let's first go through the causes of cold shock, or a decrease in stroke volume. When we see a decrease in stroke volume, or cold shock, what we're going to see is a narrowing of the pulse pressure. As we mentioned, as your stroke volume decreases, and your systolic blood pressure decreases, your body is trying to compensate by increasing vascular resistance, increasing your diastolic blood pressure, and narrowing your pulse pressure. So, in cold shock, what we'll see is a narrowed pulse pressure because our stroke volume is impaired. Our first category is cardiogenic shock. So what's the problem in cardiogenic shock? Well, it's a problem with cardiac contractility. We may see this with cardiac ischemia, myocarditis, some congenital heart disease, or toxins, which can impair contractility. As contractility is impaired, our stroke volume is impaired. This will cause it may cause a lower systolic blood pressure. To compensate, our body will increase our systemic vascular resistance and narrow our pulse pressure. Now, as you're already thinking, as we increase our systemic vascular resistance and increase our afterload, well, this again is making the situation worse because we already have a failing ventricle with low contractility. So increasing the afterload, or the work that heart has to do by increasing afterload, is going to make the problem even worse. But the body is trying to compensate and trying to maintain perfusion to organs. The next form of cold shock, or the second category of shock, is hypovolemic shock. It is usually secondary to gastrointestinal losses such as excessive vomiting or diarrhea, or from renal losses in which the patient's intake does not meet their losses. It can occur from a loss of circulating blood volume in the setting of hemorrhagic shock, where the underlying hemodynamic consequence is that a patient loses intravascular volume either from direct blood loss or hemorrhage, or other fluid losses, robbing the intravascular space of blood volume, resulting in a decrease in preload. Recall that preload is the volume of blood in the ventricle before contraction and one of three determinants of stroke volume. So a decrease in preload will result in a decrease in stroke volume. Another way preload can be decreased is when a patient develops arterial, or more importantly, venodilatation. You may remember the majority of a patient's circulating blood volume at any point can be found on the venous side, and venodilatation will result in a relative hypovolemic state where, even if intravascular volume remains the same, the increase in size of the veins will lead to a relative hypovolemic state and an increase in venous capacitance. This increase in venous capacitance is due to a decrease in vascular or venous tone, and will ultimately result in a decreased venous return and decreased preload. This phenomenon of relative hypovolemia can be isolated and as a result of certain medication side effects, but typically occurs in other forms of shock, such as septic shock, which will be discussed soon. Since preload is decreased, this will lead to a possible lowering of stroke volume and therefore systolic blood pressure. Compensatory mechanisms will be to increase heart rate, causing tachycardia, or maybe even an increase in contractility, leading to a hyperdynamic state, and an increase in vascular tone, leading to a narrowing of pulse pressure as the vessels try to vasoconstrict. Due to a decrease in stroke volume and therefore perfusion, your patient's skin may feel cold to touch. Pulses may feel diminished and capillary refill delayed, just like cardiogenic shock or other forms of cold shock. The third form of cold shock, or the third form of shock, third category of shock, is obstructive shock. Obstructive shock most often, but not always, will present as a sudden event, and the patient will appear very sick. And many times, a rapid intervention such as a chest tube, thrombolytics, or pericardiocentesis is necessary to prevent deterioration and death. The typical causes are from a venous thromboembolism, pneumothorax, or cardiac tamponade. What all three of these processes have in common is that they will decrease preload due to an obstruction, leading to a decrease in stroke volume and hypotension if not corrected quickly. In the case of a tension pneumothorax, the usual causes are from trauma, iatrogenic, for example, from a central line placement, or can be spontaneous. Whatever the cause, air will be introduced into the pleural space, leading to elevated pressures in the thorax and occluding blood flow from the inferior vena cava as well as the superior vena cava. Blood is therefore obstructed from entering the right atria and right ventricle, and there is decreased or totally occluded blood flow to the left side of the heart, and therefore to systemic circulation. And if air is not evacuated with a chest tube or needle decompression, the patient may quickly go into cardiac arrest. In the setting of a pulmonary embolism, usually a large or multiple small emboli break off from a distal venous thrombus, commonly in the lower leg veins, and circulate toward the heart, and can cause a complete or near occlusion or near obstruction of the pulmonary artery, preventing adequate forward blood flow to the lungs and the left side of the heart, leading to a decreased stroke volume and cardiac output, and may eventually lead to cardiac arrest. The typical treatment is support blood pressure until a more definitive therapy. And the last cause of obstructive shock is cardiac tamponade. This is typically secondary to trauma, post-cardiac surgery, or from uncontrolled pericardial effusions. As blood or fluid collects in the pericardium, it exerts pressure around the heart and impairs diastolic filling and decreases or obstructs preload and stroke volume. This can be diagnosed with echocardiogram and usually requires pericardiocentesis, a pericardial drain, or even window to evacuate blood or fluid and alleviate pressure and accommodate adequate cardiac filling. Distributive shock is our last category of shock, and is warm shock. The main problem in distributive shock, as the name implies, is the distribution of blood flow. Distributive shock can be caused by sepsis, anaphylaxis, or neurogenic shock. There are two other less commonly thought about causes of distributive shock: hepatic failure and adrenal insufficiency, and I will describe how these fit into this category soon. The pathophysiology, as we mentioned in an earlier slide on warm shock, is abnormal or reduced systemic vascular resistance, leading to both arteriolar and venous vasodilatation. The decrease in systemic vascular resistance will lead to a lower diastolic blood pressure and a widening of pulse pressure. Another important process in distributive shock, as you may recall in the discussion of hypovolemic shock, is the concept of venodilatation and an increase in venous capacitance and a relative hypovolemia as blood pools in the venous system. Further contributing to this relative hypovolemia is the increased capillary permeability which occurs in distributive shock. This leads to a loss in plasma volume from the vascular into the interstitial space. Although the main problem in distributive shock is the abnormal reduction in systemic vascular resistance, there is some degree of hypovolemic shock, as increases in capillary permeability result in a loss of plasma volume from the vasculature and increases in venous capacitance, leading to pooling of blood in the venous circulation, both resulting in a decrease in preload. Both the main process in distributive shock is vasodilatation, leading to decreases in systemic vascular resistance. Perfusion is then maldistributed, and blood flow is shunted away from vital organs to non-vital organs like the skin and skeletal muscles, which receive excessive blood flow, resulting in warm extremities and brisk capillary refill, bounding pulses. And this is why this form of shock is often known as warm shock. Patients attempt to compensate for their abnormal reduction in systemic vascular resistance by improving their cardiac output. This increase in heart rate leading to tachycardia and increase in contractility to improve stroke volume may often make the patient appear hyperdynamic. An important concept not typically known is that patients in septic shock develop myocardial dysfunction as a result of cytokine release, such as IL-1 or TNF-alpha. This leads to a direct myocardial toxicity and dysfunction. In fact, even though we discuss septic shock in the category of distributive shock, as this is the case in older children or adults, we see that septic shock may really fit better into the category of cold shock in younger children who develop myocardial dysfunction and have decreases in contractility, leading to a decrease in stroke volume. This can also happen in older children and adults. However, it is more commonly seen in children less than 2 years of age, but more often less than 1 year of age. There are 5 causes of distributive shock, and the specific subtleties of each may help you differentiate them from each other. We have already or just discussed sepsis, So next, let's talk about anaphylaxis. Typically, you would look at the history for an inciting event, such as a new food, medication, or exposure, and it will most commonly involve multiple organ systems, such as skin, which can cause itching or urticaria, respiratory distress and tachypnea from angioedema or stridor and or wheezing from pulmonary bronchoconstriction, as well as GI involvement, including nausea and vomiting. Typically, these patients are in a hyperdynamic state. Next is adrenal insufficiency, which will result in a decrease in cortisol production, which helps upregulate receptors on the vasculature needed to maintain vascular tone, as well as a decrease in catecholamine release needed for vascular regulation or vascular tone. Finally, hepatic failure often fits in the category of distributive shock, as there is an increase in endogenous nitric oxide, which is a potent vasodilator, causing a decrease in systemic vascular resistance. Now, all of these that I've just described will give you an increase in heart rate or tachycardia. However, in the category of neurogenic shock, which is our last form of distributive shock, we will discuss, it is commonly seen in trauma or injury occurring high in the cervical spine, leading to a loss of sympathetic output and reduced vascular tone. Typically, patients in distributive shock will be tachycardic, but patients in neurogenic shock may be bradycardic due to unopposed vagal tone, which is a distinguishing characteristic of neurogenic shock. Well, I hope you enjoyed this episode of Critical Care Fundamentals, and we will see you next time. Thanks.